So we're very interested in the management of patients with oligometastatic prostate cancer. And recently, there have been multiple trials looking at the role of local metastasis-directed therapies, particularly radiation therapy, in this patient population. However, the standard of care is to give androgen deprivation therapy, a systemic therapy for these patients. And so we asked the question, does adding metastasis-directed therapy to standard of care continuous hormone therapy improve outcomes in this patient population? And so we randomized 87 patients, 1-to-1, with a primary endpoint of progression-free survival. And at mature follow-up, we found that metastasis-directed therapy plus continuous hormone therapy improved progression-free survival compared to hormone therapy, with a median progression-free survival time of almost 4 years in the combined modality arm versus 2 years in the hormone therapy arm alone. We also performed a pre-specified analysis pooling together the results of the current trial with a previous trial we conducted looking at a systemic therapy backbone of intermittent hormone therapy. We found in this combined analysis that progression-free survival was also superior with the combined therapy arm. In addition, secondary endpoints including radiographic progression-free survival and castration-resistant-free survival were longer with combination therapy. And these results were very interesting to us, particularly the radiographic progression-free survival results, because 90% of events were the formation of a new lesion outside the radiation field. And so to explore the question of how radiation was providing systemic disease benefits to these patients, we explored immune profiles of patients treated with radiation. Because there's been now multiple preliminary studies, both using mouse models and early translational data from humans, suggesting that radiation can prime the immune system. And we found in patients with durable response, upregulation of key immune factors, including cytokines and T cells, suggestive of systemic immune effects. We validated this in our entire cohort and found it was specifically a product of metastasis-directed therapy. In addition, we sequenced T cells before and after treatment. We found that T cells that clonally expanded after radiation were at far greater number compared to clonal expansions after hormone therapy alone. And this clonal expansion process is critical because it represents the end product of the immune stimulation cascade. Furthermore, we validated this finding in the ORIOLE trial, which did not use hormone therapy, and found again that MDT was associated with T cell clonal expansion and contraction. Lastly, we determined that the most prognostic factor for patients treated with combination therapy was the presence or absence of T cell clonal expansion and contraction. Those patients had far longer progression-free survival compared to patients who have neither. These data provide important insights into the management of this patient population and suggest multiple different directions for future investigations. They certainly merit phase 3 confirmation and also raise novel hypotheses about the role of immune-based predictive biomarkers after radiation and the potential to combine metastasis-directed therapy and androgen deprivation therapy with T-cell immunostimulatory agents and T-cell engagers to further engender long-term disease control outcomes.